So that's one side of the equation, is defining the patient. The other side is defining the treatment, which kind of gets to, this, or I think we're about to go to that next slide, which is we're saying here, what do we measure? What do we, the lower part of that last slide, and what do we measure in our preparation? Back to Iain Murray and others, your nice consensus statement on what should be measured. The material, how it's processed, how it's given, all these important factors. These are, I think, the outstanding questions in the field. Until we can understand the patient on one hand and understand the treatment on the other, we'll nowhere near a precision medicine approach until we can do both of those.
That's right. And as our understanding improves, when the ISCT put forward a number of markers to define MSCs, I think we've moved on further now, and single cell sequencing has shown us that there's massive number of subsets within that wider population of MSCs. So I still think that we're in this world in biologics where we're often, and there are exceptions to this, but certainly a number of treatments have started with the treatment and have tried to take that treatment to apply it to the disease, and the whole kind of clinical translation model has been turned on its head. Instead of starting with a disease target, designing a treatment to address that target. And if we had done it that way, I think this conversation would be a lot easier, because we'd be understanding exactly what we need to measure.
Yeah, good point. Which kind of brings us to this next slide here, which is, okay, if we understand that we need to characterize our materials, we need to obtain a biospecimen. How do we really do that? How do we, Iain and Chris and Nicolas as clinicians, how do we do that? How do we take a sample? How much can we take? If we have, a small volume of your prepared bone marrow concentrate, how much are you willing to take to a lab? And how do we process it? How do we store it? How do we do this? What are we going to eventually measure? Clinically, we all talk about the importance of a biospecimen repository. Makes sense. But how do we do that practically? How can an individual who's interested, but maybe in a center where they can't do all these tests themselves, how might they procure, process, and store a specimen for later analysis? So if in the future we know 1 or 2 or 3 sentinel markers of, say, quality that we should measure, I want to have a specimen in the lab that I can go back and measure it. So how do we do that? Any thoughts on how we establish a repository of biospecimens, in a real world setting? I got a patient in front of me. I've got the cell formulation. I'm going to put this in them. How much do I take? A half a cc, 1 cc, 2 cc's? What do you think, Nicolas? Here, getting back to your extensive registry experience at the clinic there.
It's a super tough question, to be honest, and I think that we still have not figured out the answer to that question. The first thing I would say is that ideally, we would take an aliquot from every treatment we would be given to a patient. I think that the concern that we might be depriving that patient from a treatment, I think can be easily addressed, that we don't know what's the ideal formulation or concentration to provide. So we can certainly spare a little part and it could be just as little as 1 ml. We have different automated hem analyzers that are readily available. They're relatively inexpensive. I would say that the first thing is to get to know what's available in your setting. If you just go to your laboratory and ask them what kind of cell counter they have, and what's the range that they are able to measure, and then you have an idea if you're doing a PRP or a BMAC, what's the range that you'll have. And most of the hem analyzers that are available are able to manage those samples. And I think that's the first step, the first basic layer. Have an idea of what's the cellular composition of the product you've delivered, and just quantify what's the volume and the concentration, and have that as a baseline. There are a number of other things that we can measure and go more in detail, and it gets even more complex when you want to store samples and then you need to thaw them and measure them all together. But I would just start with the level 1 basic composition, and then as we determine, probably with large prospective multicentric studies, what are the basic and the minimum markers that we should measure. Hopefully we'll have a better idea of what we need to save, how we need to save it, and what we need to measure to correlate for later analysis.
That's well stated. Chris, your thoughts on, are you able to establish a repository, a collection of small specimens of the, say, of your adipose formulations that I know you've used?
Yes, I do. Practically, it's I have a lab team and I have the clinical team. So for me, it's quite practical. I can do that. But for other clinicians, it is not easy to collect or preserve any specimens. Anyway, for me, I make a registry for almost all my patients from with shoulder and knee disease. I collect body fluid like blood and a small piece of urine and a small piece of synovial fluid, and again a small piece of PRP. So this is for just for autologous treatment. And if you use another categories like allogenic cells, then this kind of responsibility should be done for the manufacturer. Maybe later, many governments or other people, other researchers should do that. But for me, so autologous specimens, I make my own registry.
That's great. And you bring up one of the important points of the resources required. So you have the ability to do it. You sound like you have a clinical staff and a laboratory staff. Most surgeons don't have those resources available. So that's the other challenge here, is just the practical logistics of doing this in a busy operating room, or even the outpatient clinic. If you're doing these treatments in the middle of a busy patient day, how do you consent the patient, collect the specimen, who gathers the specimen, who processes it, who puts it in the lab? These are just simple logistical questions that are frankly not so simple, and they're critically important. It's easy to talk about a registry, but the logistics and details need discussion.
And as a cell therapy, it's quite difficult to store a small piece of cells, because the cells should be viable after thawing. So it's not easy thing.
Right. Iain, your thoughts, since you've written about this a little bit, and again, simple question, do you do this currently in the UK?
It's not routinely done. Those people that are clinician scientists would tend to do it, but it's not routinely. And I think Chris and Nick raised really good points there. Is that I feel quite strongly that we need to know exactly what we want out of a biorepository, because as Chris says, do we want cells that are viable? In which case, the vehicle that the cells are going to be in is going to be different to if we want other data from them. And complexity comes from how many different types of biologics we're talking about. We're talking about cells, we're talking about protein solutions. All those variables will be different. And the quality of the data that comes out of the repository will depend on the consistency that we have. And it's just going to be so difficult to ensure consistency and timings and how these things are prepped before they're even put in the repository. And that's even before considering how they're analyzed afterwards. So it's a huge challenge.
It is. And there was no easy solutions. George, should we move on? Do you have any comments on the repository, question?
No, Scott, thanks. This is challenging. I mean, in building this bridge between the variation that exists between patients, and and Nicolas, you mentioned this that patients vary, as you all know, right? Even if 80% of our patients present with medial joint space narrowing in a knee, and that's the primary focus of osteoarthritis, still 15% present with primarily lateral compartment disease. 5% or so maybe present with primarily patellofemoral disease. They may or may not have contractures. They may or may not have instability. They may or may not be overweight. They may or may not have other joints involved. And so all of those factors are profoundly impactful on their severity of the disease. But then, as we've shown up, we've published for a number of years on bone marrow aspirates, and there's 2 orders of magnitude variation between bone marrow aspirates on different individuals. And most of my patients have been in the arthroplasty age group, but I have aspirated people down into their 15s or 15 to 18-year-olds, and there's a predictable decline in cellularity over age if you take the statistics, but being 80 doesn't mean that you're not going to be better than somebody who's 30. There's huge variation there in the number of cells, the number of progenitors, and in the biological environment from which you're harvesting that tissue. And there are, as you know, bone marrow diseases that people sometimes have but don't know about that may impact on the quality of the marrow sample that comes. And so all of these variables are things we have to grapple with and manage, and we don't have the tools to do this very effectively now, but it is absolutely something we have to do together. Not only simplifying the process of defining what of those many clinical variables to collect, but also Chris has done an outstanding job, and several others have done an outstanding job in their local community of creating a bank of cells and a bank of proteins for analysis and a bank of data that could be used for subsequent mining. But for most of us who've tried to do that, we realize that the first 10 samples we put into that bank are much more likely to have problems than the next 10 samples and the next 10 samples. And if everybody's doing this and contributing only 5 or 10 samples to a larger registry, the chances of all those samples really providing good data starts to get pretty limited. So that if we're going to do that, it really is going to require a concerted effort across multiple labs where lots of samples get collected in exactly the same way and stored in exactly the same way and analyzed in exactly the same way. So it's going to take a whole community of people that are committed to participating at that level.
Yeah, you're right. The challenge, standardizing our approaches is critically important, but certainly a challenge, a real challenge.
And some of those things, they can be started with relatively little resources. A very interested student, a freezer, and a clear protocol. Many of our universities have biologic repositories that are relatively inexpensive to store tissue in increasingly. So those are options, but they still cost $50 to $100 per patient at least. And so finding the money to pay for that and putting away samples that can be selectively pulled out for harvest, that'll be a lot of what we hope to contribute to going forward.
I think it's an incredibly important area. I mean, everybody acknowledges and states the importance of quote unquote characterizing these treatments, but how do you do it? The devil's in the details, and where the rubber meets the road, and how do we really carry this out in our centers? And the reality is may only be in some of the major centers that have the resources and infrastructure to kind of do this, quite honestly. But hopefully we can, with those studies, identify what are those, hopefully several feasible, practical measures that can be done on a more widespread basis. So.
And we're talking as we get closer to the end about what types of things can the Arthritis Foundation use their forum for. And one of the tremendous resources that the Arthritis Foundation has created, not just funding research, but bringing people together around these problems. So thinking about what is needed in this space to make this important next step, and thinking about what the Arthritis Foundation can do, perhaps in concert with NIH and with other potential sources for funding and for oversight. This is an area where we as clinicians could, I think, use a lot of help.
Absolutely.